Welcome, everyone. This is the fourth Lunch and Learn webinar in our five-part series for the healthcare industry. Today's topic is called Hot Topics in Physician Employment Agreements, and I'm here with Ronnen Isakov from Medic Management Group. And our goal is to really, it would be great if everyone could walk away from this discussion with just a few pieces of practical guidance that you can use in your own practices or organizations. Let's see. I'm Kate Hickner. I'm a healthcare attorney. I'm a partner at Brennan Mann & Diamond, and I have a national practice that focuses on mergers, acquisitions, capital raises, and other types of corporate transactions. I also spend quite a bit of time on physician relationships and review numerous physician employment agreements every week from both the employer and the employee perspective. I spend a lot of time providing regulatory and compliance guidance. And I'll let Ronnen introduce himself.
Sure. Okay, thanks again for the opportunity to do this with Brennan Manor, and we always appreciate it. And actually, it's nice to see some of our familiar names on who are joining us this morning or this afternoon. So I appreciate that. As Kate mentioned, I'm Ronnen Isakov. I'm the managing director of our healthcare advisory group here at Medic Management Group. MMG is really an MSO for physician and hospital-based practices based in Ohio, but we do work across the country. And I really lead our group on our advisory and consulting side from fair market value, compensation agreements, specifically as we're talking through the items tonight and this afternoon in areas of different focus, especially, as I said, on both independent private practices as well as hospital-owned, employed, aligned groups, and getting more and more involved with venture capital and other purchasing groups out there that I think we'll go into a little bit during our discussion this afternoon.
Okay, thank you. So I'm going to go first and run through a few slides and share some legal considerations and things that I'm seeing in my practice, and then Ronnen will probably provide the more interesting content and talk about the business considerations. So he always does a good job in that regard. Okay, and before I get started, I just wanted to say a few words about the current environment here, and just to give us a little bit of a backdrop. So up on the slide, you'll see the quote that says that the percentage of U.S. physicians employed by hospitals, health systems, and others grew from 62.2% in 2019 to 73.9% as of January 2022. So definitely there's this movement towards an employed model. Surveys are showing that younger physicians are more and more interested in work-life balance than prior generations. And, you know, a lot of them feel that really the quality of their life and job security will be better if they're employed as opposed to practicing in private practice. But there's also another dynamic that's going on. Some physicians don't want to be employed, and they're feeling quite a bit of pressure from the health systems. I just put this quote up here because it struck me. It was in a Becker's article that I read recently talking about Hartford Healthcare crushing the physicians if they didn't become employed. You know, a lot of physicians do value autonomy, and they lack trust of the larger practices and health systems. So these physicians brought litigation against Hartford Healthcare, accusing them of anti-competitive effects to acquire more physician practices. So there's a lot of tension out there and a lot of competing interests. And it's important to kind of remember that backdrop as we're reviewing relationships. There are many laws that impact financial relationships, including physician employment agreements. I'm not going to spend a long time on this, but I just want to make sure we're on the same page about some of the most basic requirements, because it does impact what I'll be discussing today. So for those physicians that bill Medicaid and Medicare or federal health care programs, their employment agreements are often subject to Stark and the anti-kickback law. There's also state level fee splitting laws. These laws are, depending on the state, often found within the physician licensure requirements and the medical board rules. There's corporate practice of medicine requirements and tax exempt laws as well. So just a few things about kind of the key laws here. The federal Stark Law, it's a broad prohibition subject to exceptions. So the Stark Law prohibits a physician from making referrals to an entity for healthcare services if the physician has a financial relationship with the entity. And when that prohibition applies, the financial relationship has to fit into an exception. And of course, there is one for employment relationships. It in general requires that physicians be paid only based upon their personally performed services. So physicians within group practices can share in ancillaries, but not physicians that are relying upon that employment exception and employed by hospitals. And there's a lot of nuance there, but that's kind of it at a high level. A few words about the anti-kickback law. It's a criminal law, federal, it's federal law. There are parallel state laws as well. And in its simplest form, it's, a prohibition stating that we can't pay for patients or pay for referrals, but it's much broader than that. It basically means that, someone cannot give anything of value to someone in exchange for generating business. And payable by the federal healthcare programs. And then the state parallels to the federal anti-kickback statute often apply to commercial payers or private pay patients, cash-based practices as well. So from the government's perspective, if one purpose of the relationship is to reward someone for the generation of business, that's enough to taint the entire relationship and make it impermissible. The government views payments in excess of fair market value as a payment for business. And we'll see that kind of concept come up through the next few minutes. Okay, so before we move in, I just want to say kind of big picture, stepping back, why are these laws in place? What's the government thinking? Because it helps us to analyze the relationships. A few reasons. So as we all know, the government's concerned about business practices that result in overutilization of healthcare services. Overutilization means providing more services than are necessary. Why? Because they're worried about unnecessary cost to Medicare, Medicaid, and other payers. And so the government wants to make sure that physicians and other providers are making decisions that are in the best interest of the patients and not that the decisions are being made because they're financially motivated. So those are really important concepts to remember as we analyze relationships in this space. For purposes of this short discussion, since we only have a few minutes, it's just a brief lunch and learn, I thought I'd touch upon 3 comments that I hear most often from physicians lately, just within the past few weeks. Of course, I hear, they don't understand what I'm worth. No physician wants to hear that, out of, for example, 4 tiers of physicians, they might be in the 3rd tier. Oftentimes physicians always think they should be paid at the 95th percentile and that they're in the 1st tier. From a legal perspective, fair market value becomes a legal concept, a legal requirement because of the laws that I just mentioned, kickback, Stark, and the tax exempt laws, and then parallel state laws. So the compensation paid to physicians needs to be fair market value. And fair market value has a special meaning in healthcare. It's defined actually in the federal law, and it means that we can't take into account the generation of business. So oftentimes we don't have the resources to obtain a third-party valuation on each employment agreement. The employers oftentimes rely upon third-party surveys like Sullivan-Cotter, MGMA. It's not legally required to obtain a fair market valuation, but if you don't, and you're subject to these laws that I mentioned, then it's imperative that the employer and the employee come up with a reasonable determination, good faith determination of fair market value, usually based on comparables, and that's documented in the file. I placed a few kind of hot topics that I'm hearing with respect to compensation on the slide up here. First, compensation stacking, or I guess that's the second thing on my list. Kind of thinking about the aggregate compensation for all the different roles that a physician has versus each component. So, for example, sometimes we see physicians paid for call coverage, medical directorships, clinical services, administrative services, and sometimes these add up to more 1 FTE. And so those reviewing the relationship have to actually think, can this physician really be paid more than one FT? Can they really do that much work? We really need to consider all of these components as a whole. Also, the defensible analysis process, we need to think about what's the process for determining fair market value. Is it defensible? If you're using the surveys that I just mentioned, the WRVU benchmark data, it has to be reviewed carefully. For most physicians, compensation for WRVU should remain at the 50th and 60th percentiles. And that's contrary to what a lot of physicians think. But that being said, fair market value is a range, and there's often room for negotiation here. Also, just a word about commercial reasonableness. I listed the big three up here. The government refers to the big three as fair market value, commercial reasonableness, and then whether the compensation fluctuates based upon the volume or value of referrals generated. So we need to ask ourselves, is the arrangement commercially reasonable? We need to make sure if there's 2 medical directors, that those are really needed. If there's only one needed, then it's not permissible to have a medical director with a physician, even if it's fair market value, because that work isn't really needed. Another comment that I often hear is, this non-compete isn't really enforceable, is it? Why would they enforce this against me? The answer is that it probably is enforceable in most states anyways. Under state law, non-competes and non-solicitation provisions are generally enforceable if they're reasonable in terms of scope and geographic area and duration. And employers place non-competes in their agreements for a reason. They believe they're important. And these provisions can definitely significantly impact a physician's career. That being said, sometimes we do have success with employers, especially when the employee has some leverage or there's some potential claims that can be waived. Sometimes we will, persuade an employer to waive a restrictive covenant like a non-compete, or at least reduce it, or maybe insert some carve-outs. Just a word about non-solicitation provisions as well. Some states have required notices to patients upon a physician's departure. So Ohio, for example, where my office is located, there's a medical board rule that requires that most employers provide notice to all of the patients that a physician has seen within the past 2 years if they depart. So that really kind of undercuts against the importance of a non-solicitation provision. It's important to kind of know how all of the requirements interact. I heard this just a few weeks ago. A physician called me and was very distraught. He said, they promised him he could work at the hospital near his home, but then they changed their mind. The hospital system that hired him made several promises during the recruiting process that were not in writing. And one of them was that he could work at a certain location. And when he started, they notified the physician that they were going to move him to another location, almost 2 hours from his home. There was really nothing we could do from a legal perspective. And he'd have to resolve the issues politically. So the lesson is that whether you're the employee or the employer, all verbal promises need to be in writing. In addition to practice location, I would consider equitable call coverage rotations, permitted outside activities and investments, weekly schedules, any sort of support that's been in terms of resources that have been promised or that are important. Yes, there is a degree of trust that's required in all relationships, but it's also very important for physicians and the employer to advocate for themselves, to be on the same page at the beginning so that there aren't disputes that come up down the road. And so one of my jobs as a lawyer is to really think about worst case scenario when I'm negotiating an employment agreement so my clients really don't have to. And I guess that's kind of what I wanted to cover in my slides, and then we'll have Q&A afterwards if anyone has any questions. And with that, I'm going to hand it over to you, Ronnen.
Yeah, no problem. Thanks. So I'm definitely going to be covering a lot of similar items that Kate covered, just from a business and operational perspective. And right here, one of the things with always, what's changing in the the healthcare industry, which often affects compensation and employment agreements, is what are the challenges we're all facing. And so I actually pulled this from maybe a couple of years ago when I did a similar presentation, which was really the focus away from fee-for-service to more kind of closing the gap of quality, reducing cost, real focus on bundled payments for services, which I list below, and PCMHs, shared saving program. We're doing a lot in the currently Medicare and Medicare Advantage program. But I want to go back to one of the first slides Kate shared with everybody, and that was just the change in the amount of the increase in employment in the industry. And if you all remember her slide, Kate, I might have it on the next one actually, if you want to go down one slide. Right here, right? So you can see basically in a 3-year period, we were basically on the same page, Kate and I, about an almost 11.5% increase in 3 years employment. What we've really seen over the last 2 years, specifically around the COVID period, is about, of that 11%, about 10% increase. So in between January of 2020 and January of 2022, there's about a 10% overall increase, which is about, when you convert it over to about a 3.5 million total employed physicians, not compared to about 3 million where it was before. So COVID has definitely played a significant impact in the last 24 months in the move towards employment, both from a health system, hospital system, and as I mentioned right at the beginning, we're seeing more and more in other means, venture capital groups, insurance companies, getting into the employment market. So all these are playing an effect on the different agreements that are there, compensation agreements, and so forth. So I thought this was important to share as well, and Kate and I were clear on the same page. If you go to the next page, thanks. So as you mentioned, again, I'll just go from a operations advisory perspective. When Kate talked about the anti-kickback statute and the stock law, for us, when we're looking at payments made to physicians for fair market value and commercial reasonableness, which you mentioned, we really try and look at that as I mentioned on the what else, similar physicians for similar services in similar regions. And as you mentioned, and we do this very similar work when we're helping and assisting our clients, both on the buyer or seller or the employer or the employee side. The question of performing the services for rendering for what you actually did is really important. We have a lot of groups that have mid-level providers, APP providers that are part of their practice, who perform a lot of the services, but they do a thing called incident to billing, where it's billed under the physician. And so in the physician, and they present all their data, historical data, to groups that are looking to purchase them. They are thinking that all that activity that is done under the mid-level or under the APP kind of falls under them, and that is not often the case. Again, there's a real focus on you having to provide the services or the rendering services for what you're performing personally. The importance, again, on fair market, as Kate mentioned, is we're definitely looking at national benchmarks. She mentioned a lot of the ones already. There's a couple of other groups and surveys that are out there. And it's important that when you're looking at survey data, you can't always each separate ratio separately. So what I'm saying with that is, when you're looking at total work hour years performed, so they have different metrics, 25th, 50th, 75th, 90th percentiles. Again, as Kate was mentioning, we're totally in agreement. We really should be looking at what median area is. When you're looking at work hour years, for example, total work hour years, and then you're looking at total collections, two different numbers, and then there's a ratio of looking at I'll go into a little bit. It's one of the big models on a conversion factor when practices are looking at, I get a certain amount of dollars. They just say I get $40 per work hour year. That's my compensation. they can't automatically just take the work RVU number and the collection number, get their own ratio and say how that is, because the benchmarks look at it differently as well. So those are all important things to be thinking through as we look at fair market value and commercial reasonableness. But Kate really went through the importance of the Stark law. Again, it's all about being the services rendered. And if you go to the next slide, Kate, I'll give a little bit of a definition here. Again, from a healthcare perspective of what it is, again, I'd rather you focus on the legal side, but the price at which property would change hands between a hypothetical buyer and hypothetical seller, when neither is in a position to generate business for the other party. So it's all, again, about ensuring there's no referral for services that are not being performed. So again, the definition attempts to work all concepts previously mentioned, definitions into one statement. So fair market value, commercial reasonableness, the same thing, how it applies from a legal perspective, applies from an operations and an advisory perspective for us as well. Next slide, please. So the gist of, in my time, again, I think we're trying to keep this pretty high level and give folks the chance to have some questions. I'm kind of going to go through about 6 different models this morning to talk through the ones that we're seeing. There's always a different options out there. There's various hybrids of each one of these that we could go into, but from a high level, we'll start from kind of a high to low. And the first one I call the salaried model, or the Cleveland Clinic Mayo Clinic model, which a lot of you on this call might have seen or come across. And that is truly where, for a majority of the employed providers of those 2 entities, they're on a straight salary for the services that they provide. Some of them do provide, some of them do have some bonus opportunities on various different areas, if it's a productivity or non-productivity based opportunities. But for the most part, those salaried models are 1-year agreements that will get renewed every year. And they are basically highly compensated, if you call it highly compensated physicians or providers for the services that they're performing, straight W-2 income. And they go for, and that's kind of where they are. Then the next one I call, well, the net income model, or the eat what you see. I know there's got a lot of different terminologies for that one. And this is for the most common independent private practice model. And I put a note there, it's eat what you see, but after you pay everybody else. And this is specifically for most shareholder or owner groups, that what they're doing, again, it's their collections revenue in versus all expenses out, and whatever's left over is their payments. The net income model, again, you'll often see it for both employed and shareholder-based opportunities. So private practices that employ non-owners or non-shareholders have a net income model as well, where they're kind of guaranteed a base for services, for a certain amount of collections, and then they get some opportunities or some bonus opportunities that are at risk based on additional collections that they see and where they are. On a shareholder one, for most of our private practice groups, again, it's a draw of income. So they take a modest draw after they're paying all the expenses, including administrative, general, and direct expenses for the employed providers. They get to reap the benefit of whatever's left over. What we will also see is on diagnostic or ancillary services, again, based on Medicare and Medicaid rules of how that income can be split versus commercial payer. There's ways to do different type of models within the net income model itself. And again, happy to discuss that at another stage in more detail. But that is the most common, if you'd call it, the independent private practice model. What we're also starting to see a little bit more of is my third bullet point here, called the collections-based model, which is really a change of the compensation is pegged to a percentage of collections. Often seeing that with new providers coming into smaller, new established practices, where they'll say, okay, you know what, we've worked out based on historical information, we will pay you basically 40% or 40 cents on every dollar that that you bring in. We'll be responsible for all the receivables, all the expenses that relate to it. You just get a single volume number. Again, based on a percentage of collections. Seeing less and less of this model in the last few years, but every now and then it'll still show up, and we're dealing with it. Again, I just want to remind everybody in all these different models that we're talking about, especially for those groups that I know that are on here that are hospital system based or larger group based, you're still having to look at, as we talked about from the beginning, how this falls in within fair market value and commercial reasonableness. All right, the fourth one, what I call the straight productivity model, or the dollar per work hour RVU conversion factor, which is, I would say, still today the most common health system employed model. And that again it's similar to the collections-based model, but it's all based on the conversion factor of a dollar amount per work RVU you bring in, and making sure that everybody on our lunch and learn today is comfortable and understands the work RVU for each volume or service or CPT code that is built for the services that provide. There is a specific dollar factor that goes to that work RVU. The work RVUs are calculated, and by specialty is the same. So no matter if you're a cardiologist or a primary care physician, when you do a level 3 established visit, for example, a 99213, that work RVU related for that service is the same. However, the conversion factor based on again, a lot of benchmarking, a lot of data of looking at other related practices around both regionally or nationally, you will see a different conversion factor for almost every specialty out there for their total services. So a cardiologist might be receiving a compensation package that says $50 or $55 per work RVU, and a primary care family practice internal medicine provider might be receiving something in the mid-40s as a conversion factor. Again, their actual volumes or the work RVUs that they're producing could be different, but it's all based on that work RVU factor. As I mentioned, the most common from a health system perspective, you don't often see it in independent private practices. I do have a couple that do use that model, but again, it's more of a system-wide. All right, the next one, as I mentioned here, is kind of, I call it the academic model. And that is more of a collaboration of various services that in an academic institution, a provider is normally expected to do. And that includes clinical, administrative responsibilities, academic responsibilities. Most of them have a research percentage of allocation within their compensation package. And this ties in really well to what Kate mentioned a little bit earlier around the thing called stacking. And I'll go into that again. And what that again means is when that model is put together, is that 1.0 FTE, and again, a lot of our academic providers, some of them are we have a decent amount that receive part-time as well as full-time, that whatever that total work that they're going to be doing gets broken out as a percentage of clinical, administrative, academic, and research, as I mentioned below. And so each portion of their compensation package has an allocation. So for example, a physician has a 0.3 clinical requirement, a 0.2 administrative requirement, a 0.2 academic requirement, and a 0.3 research. And they have to be allocated for that amount. We should be able to keep logs of the services that they're doing or tracking. So when I say a 0.3 research, literally, as I say, that works out in theory to about 16 hours a week, is that provider is really focusing on research. We'll often see, as I mentioned below, additional on-call or medical directorship responsibilities. So most of our health group, of our system groups have call requirements as part of their employment. But then if they do above and beyond a certain amount of call, they get paid extra, or if they have a medical directorship responsibility, they get paid extra. As Kate mentioned, again, the importance of understanding this whole thing when it comes to stacking is, at the end of the day, is it reasonable for a physician who has all these different hats that they're wearing, and all, from research and academic and administrative and clinical, and they're doing on-call and they're doing directorships on a sustainable methodology. Can they be working all that work? And that's where we get into that stacking responsibility. The final one I want to talk through, and it's an area that we're seeing more and more, and I'd say the most common over maybe the last 18 to 24 months, maybe a little bit more longer down, is truly these hybrid models. I often see that in the venture capital backed employment agreements, but I'm seeing it more and more for sure with our both actually independent practice groups as well as academic and health system based groups, is that we're starting to see a lot more of a hybrid model. And what that really is a true combination of productivity and non-productivity, or I call it at-risk incentives. So that basically what we're taking is all those 5 different models that I just talked through and picking and choosing and doing more of a hybrid, of a combination of where we are. Because I think what we're seeing is, as we do slowly move away from true volume-based reimbursement, and we're starting to see a lot more value-based incentives out there. Commercial payers are putting a little bit more in from a value percentage. Our health system, Medicare, and is looking at those different models. We're starting to see, right, we have to employ and employ providers and have a compensation model that really encompasses more the work that they're doing. So areas such as quality, so their quality metrics, governance, how involved they are with the health system. We often see this Press Ganey or employee satisfaction surveys coming into the compensation model. And also, as I mentioned, the last point is really group incentive metrics. So we're not really just compensating a provider on their own individual incentive, but more really what they are as a group, as they are within their specialty, within the whole health system, how they're helping to meet those group incentives they're getting paid for. The last two, sorry, I think my font was a little bit bad, but just so you can hopefully see, we're starting to see more things reimbursement related to panels. So Medicare or Medicare Advantage, your actual panel size, where the size of your patient panels, we are seeing some groups are putting some more emphasis on that because again, they're looking at what you're going to be doing with your Medicare or your Medicare Advantage lives, how you're controlling your panel, how you're controlling your costs. And that really is where our focus on the value-based and the shared savings. So again, cost control, real focus on not just getting through volumes, but value is really where we're starting to focus a lot of our compensation plans that we are putting together and helping groups as well as advising on. So from a big picture perspective, I think those 6 models cover a majority of what's out there, but absolutely we're seeing offshoots of each one of those as we continue. So I just want to leave one or two last things. From a non-production metrics, the effect on fair market. I know that's been a question that often gets brought up. And again, as we've mentioned more than once, the fair market value continue. We focus on surveys, and surveys really don't currently have good metrics or good capture. How do you capture non-productivity metrics? How do you capture quality scores? How do you capture patient satisfactions? Areas like that. So that is becoming more and more focused. I think these national surveys and the benchmarks out there will start catching up as more and more providers are compensated for a portion of this type of service. But it is something for us to think through. Next slide. These last 2 slides, again, kind of off subject, but on subject. I just thought I would just show a couple of areas of overview of what we're starting to see with system and community alignment models. Don't have to go into too much along this because this does still fall into how then it relates to employment. But for those groups that are on with us, that are system-based, we're starting to see a lot more affiliation type models, professional service agreements and physician leasing, direct leasing, We're looking at co-management and service line areas. We are starting to see more and more health systems looking at possibly doing a minority investment in a group. And then the last two slides are really, as I keep mentioning, is it's come more these risk platforms as we go to value-based focus. And this is a table that I'm sure Kate will be sharing our slides with everybody that's on. Just some different model perspectives from the co-management, minority investment, all the things that I thought of that achieves health system goals, that doesn't, that's neutral to everybody else. So just some extra points I thought that I would throw in